Thank you very much, Kathy. And again, good afternoon to everyone. And looking at the international composition of the audience today, I should probably say good afternoon, good morning, and good evening. While I set up my slides in the meantime, I welcome you again and want to highlight that this webinar is organized and offered to you by the EAPC Reference Group on Public Health and Palliative Care. We are an EAPC reference group, but we want to engage with you, we want to update you, communicate with you. If you are interested in hearing more about all the events that we are doing, all the output that we are generating, do sign up for our newsletter and you can use the QR code that you find there. So as a reference group, the big aims that we have are to promote and to disseminate and improve palliative care via public health approaches. And a second aim is that we want to develop an international network of researchers and organizations that are interested or involved in public health and palliative care. Now, you might be wondering, and there is a bit of discussion in the literature about what actually constitutes this public health approach to palliative care. And here's, for instance, one article out of a series of articles where we have tried to define and describe what we think typifies or defines the public health approach to palliative care. And palliative care is often narrowly viewed as a healthcare service response to the needs and problems that are encountered by patients with serious illness or their family. Now, applying a broader public health approach to palliative care, it really extends that focus to beyond the healthcare service to the various possible strategies and responses to these issues and problems. And we can maybe distinguish several types of these responses. And the first type of responses are dealing what we call with assurance or ascertainment. It is what is often called the WHO public health approach to palliative care, and it's dealing with governments that ascertain or set up a reasonably trained workforce, setting up services, assuring that people have equitable access to good quality responses, good quality services. A second type of activities or functions is what we call the action component. So this is dealing more with the different programs in which we try to make the environments in which people live, work, study, while they are facing these experiences of serious illness, of caregiving, of grief, and trying to make these environments supportive to those experiences. And in past webinars that we have organized with the reference group, we have focused a lot on this action component. These were webinars that were talking about, for instance, compassionate communities, compassionate schools. In today's webinar, we want to focus more on the assessment component of public health. And this is more the traditional epidemiology, population health component that is concerned with assessments in the entire population about the health and well-being around serious illness, dying, and grief. And in looking at what are the causes and determinants of these outcomes. So today's webinar will indeed focus more on international and cross-national comparisons in palliative care research and applying those population health perspectives. Unfortunately, I have to announce that the first announced speaker, Agnes van der Heijden, has been cancelled, and I don't mean that in a social cultural manner. I mean, she had to cancel this webinar for personal family reasons, which are very unfortunate. But then this means that the two other program speakers will have slightly more time for their presentation, and that we might also have more time to engage in a discussion and Q&A with all of you. And again, as Kathy had said in the introduction, please do use the Q&A to formulate any questions that you have to the speakers about their methodology, about specific aspects that weren't entirely clear to you, or about large discussions that you want to have with them. So our first speaker will be Professor Tania Pastrana, who works in the University Hospital in Aachen in Germany. She will give a presentation about the epidemiology of dying and palliative care needs in Latin America. And you might be wondering what's the connection between a person from Germany and Latin America, but many of you know, of course, that Tania Pastrana has also been the president of the Latin American Palliative Care and Hospice Association. And then the second speaker will be Barbara Gomes, or Barbara Gomes, I think, in Portuguese, because she is from the University of Coimbra in Portugal. And she will talk about research that is linked to an ERC project of her, looking at the importance of place and end-of-life care and death, and discussing the policy implications. It is now my pleasure to give the word to the first speaker, to Tania Pastrana. And I'll then stop sharing.
Yeah, thank you. Hello, everyone. I thank you very much, Joachim, for the invitation to this webinar. And I thank you all the participants for choosing to join us for this session. As Joachim said, I'm Tania Pastrana, and my Spanish accent is because I'm Colombian, not just the president of the Latin American Association. And I have dedicated many years to exploring the palliative care situation and the challenge in the region. Today, I will speak about the epidemiology of dying and the palliative care needs across the region, and I will share my screen now. It works once. Can you see it? Yes? Okay.
Yes.
Well, when I refer to Latin America, I speak about 19 Spanish and Portuguese-speaking countries here in green. And this region is home of over 60 million people. That is about the 8% of the world population. That includes three high-income countries, Panama, Uruguay, and Chile, and other middle-income economies. And this reflects also a little bit the diversity and the complexity of the region. Latin America remains almost invisible in the global palliative care landscape. For this reason, I sincerely thank you for this opportunity. When you think about Latin America, probably you think about these beautiful landscapes and joy now in the carnival time, and maybe music or some complex problem with drugs, and maybe some writers too. And if we speak about death, probably you think about the Catrina, which is become an iconic symbol of the Dia de los Muertos, or Day of the Dead, which is a tradition, beautiful tradition, especially in the north of Latin America. I will speak today about another perspective, and I will give short introduction about the demographic, but also about the case of death and the need for palliative care in the region. And I will show you where people are dying in Latin America and what affects it. And finally, I will share some reflections and about this general talk. I have more time, so I expand a little bit my presentation, but I hope it's in frame of our time. The population in Latin America is relatively young, with a median age of 31 years, in contrast to the median in Europe of 42 years. But it is gradually changing, and you can see here that this pyramid has become a little bit like an onion shape, reflecting the transition in the demographic. In Latin America, the proportion of older population is growing. As you can see, I highlight here in yellow. That is a positive development because it reflects the improvement of the socio-sanitary systems in the past decades, but because the alternative is to die at younger age, also it's good to die in older. But also that leads to a higher prevalence of chronic and non-communicable disease that demand much more palliative care. And it needs also sociosanitary systems that are prepared for this, for facing this need. It's not a problem, it's a change. We see also that the society has changed in Latin America, where it was much more a traditional society with a lot of big families living together. Now, the extended family are not so much. And we can say that the richer the people, the more alone are they living. And I read in nowadays that people who are divorced, in the past, they come back to their families, to the big families, but now they stay alone home, especially people who has much more incomes. Well, there are some changes in the population. But what do people in Latin America die from? I researched this statistic of the WHO. Maybe you can read very well. I don't know, but I choose the 10 leading causes of death in each of the countries. In this heat chart, you can see the intensity of the color represents the frequency of these causes. Also, if you see that, you can see the variability across the region, but also there are some common diseases also in the different countries. Also, we are similar, but not so like equal. Also, there are a lot of differences. The first point is the significance of proportion of the so-called non-communicable disease. Here I highlighted in bold. They have the much more impact in the mortality in the region. Most of them, also, they are not communicable, but we know that some cancer disease, we know they have an infectious origin, but they are non-communicable disease. They are the most important cause of death in the region. But we have here, you can see some other infectious disease, communicable disease, like respiratory infections, tuberculosis, diarrhea, and HIV, which are tuberculosis and HIV also important. Can be, the people dying of that can be benefit from palliative care. Also, and COVID is the first one in the 21, as you know. But people also are dying from diarrhea and respiratory disease, which means this double burden of diseases in the region, also infectious and non-communicable disease. And a third cause of death are, that make me really sad, is violence and accidents. And really sad because the interpersonal violence is one of the most important causes in 10 important causes in many of the countries, include Colombia here with 36%, deaths per thousand population. And it is especially sad because they are the young and healthy people which are dying mostly in very young age, mostly in the teenagers. But well, there's according to the ACE 2.0, there's, which I have to say in the few weeks you will be able to read the World Report, the World Paper, I hope so. There are over 4 million people in Latin America, descendant and non-descendant, experiencing serious health-related suffering. You can see here the comparison of the distribution between 1919 and 2019. And at the moment, we calculate almost 2 million people who die with experiencing significant suffering. No? And we can see here that the huge increase in the amount of people, especially in the older ages people, but also that there is a reduction of the need of children. Yeah? Also there are an improved reduction in the infant mortality. Now it's approximately in the 15 per 1,000 live births. However, that is almost 4 times higher than in Europe, which is approximately 4 per 1,000 live births. Well, one of these persons who died in 2019 was my grandmother. Here is my grandmother, Aura. She passed away at the age of 103. She has COPD, also respiratory problems with oxygen, and she suffered from a bladder cancer that blocked the both ureters and led to a complete kidney failure. She was hospitalized in a private facilities, receiving intravenous antibiotics and fluids. The nephrologist said me, I will not perform a transplant and stent, a dialysis, and she will not go to the intensive care. And the only thing that she wants is to go to the rancho, and she was frustrated and upset because they keeping putting racks in the mount, also for the mount care. Yeah? And I spoke with the family and about the prognosis and the condition, and together the family decide to take her home. However, a young doctor strongly opposed to this decision and say she needs dextrosa, she's not eating, and she could have seizure from hypoglycemia, so not eating. In our ward, we see nearly one death every 2 days, and deaths from renal failure especially are often painful. Ultimately, the family decided to take her against the medical advice. My sister-in-law, which is a medical doctor with a basic training in palliative care, supported her. And she go home. My grandmother at home, she asked for fruit juices and were overjoyed to be back in her rancho. No? Her children, grandchildren, great-grandchildren visit her, and we were able to say goodbye. She was very religious. The priest, the father was the sacerdote was at home speaking with her, and she died 4 or 5 years later, very peaceful at home without seizures, no? And with minor breathing difficulties that were managed with opioids. I witnessed there the failure to establish her prognosis at the hospital as of few days, and the difficulty to face the inevitable outcome. She will die, as there was not other outcome. And instead to provide reassurance and support the family from the healthcare provider, the doctor create fear and actually fictive fears and uncertainty. Yeah? And when she would stay at the hospital, she would die alone, angry and sad, with no family around, because the hospital is not possible to go to get out the family. Well, that was for me very, very awful, actually, this experience. And there is palliative care in Latin America. The origin of palliative care exists so long, like in Germany. It started in Colombia, Argentina, Brazil in the 18th, similar like I say in Germany. And there is at the moment in the whole region some kind of development. We have studied that in different atlases together with the LCP, the American Association, together with the Universidad of Navarra. And we analyze also the change between, that's my colleagues, the very hardworking colleagues in the region have done in this paper. And we have a lot of advance. We in Latin America have a lot of advance, but these efforts, out of this effort, the progress has not kept the pace that is a growing need for palliative care that I showed you before. Well, where do people in Latin America die? Not all people are so fortunate like my grandmother to die at home, surrounded by her loved one. I think Barbara will say as why it's so important to study the place of death, but well, we, together with the End of Life Research Group in Brussels, we initiated the project Place of Death in Latin America, where we count with a group of colleagues and friends from Europe and Latin America who respond to this initiative, and we were able to analyze a little bit this where people are dying, this question. We did a literature review and found 21 studies. Most of them come from Mexico, Brazil, and Chile, and there are some countries which has no idea where are people actually dying, especially people with palliative care needs. The quality of the studies were very mixed, some good, some not so good. And the methods and classification system were quite different, which makes it very difficult to compare results. Maybe we need some standardized method to bring more consistency of future research. What we did was collect the certificates from all the countries, the 90 countries, and review whether they have place of death record in the documentation. At this time, Bolivia the certificate has no place of death in the certificate. Also drop out. We collected digital archive for 1 year which include individual cases and sociodemographic characteristics and cause of death. And it was possible to find for 12 countries. And we assessed the quality of the data. It was medium to high quality. And finally, we construct a comprehensive database that brought together information from all the countries. The data set results in more than 3 million cases from these 12 countries. These countries, as you can see here, which one, they represent the 90% of the population in the region. And I refer to these years that you can see, 2016, 2018, and more of them were in Brazil and Mexico, which are the most bigger countries in the region. The mortality was between 0.4% to 1% of the population in each country, as you can see here in the database. Well, this data shows the percentage of people by age group, and the darker bar represents the oldest group, over 70. You can see here Uruguay has the highest percentage of deaths among those over 70 years, suggesting a more aging population compared to other regions. But also, I say this is a high-income country. Guatemala, in contrast here, shows the lowest percentage of deaths among this older population, with a huge percentage of people dying in early age, what we consider the so-called premature deaths. Well, most of the countries, in most of the countries, over the 50% are dying in over 70 years. In this other chart, we ask where people are dying. You can see here in purple, the people dying at home. And we see a huge variability in the region going between 20% in Brazil to 68% in Guatemala. And so these are in Central American countries, Guatemala and El Salvador, and there are much more from the south, Brazil, Argentina, Colombia, which people die mostly at the hospital. Well, let's look Guatemala. That is Antigua in Guatemala. It's a dream city. I love that. In Guatemala, we saw 68% of people are dying home. And in this beautiful landscape, you can imagine something like Monica Landala envision of the ideal experience of dying, surrounded by family, music, flowers, probably, and offering peace and comfort. Let's see how is the situation there. In Guatemala, died almost 82,000 people. Most of them died home. This is 50,000 people. Approximately 37,000 of them will require palliative care. However, there is less than 1 bed per 1,000 inhabitants in the whole country, and 9 palliative care teams, almost all of them located in Guatemala City, and in Antigua there is no teams at all. So what happened with the 75% of the population outside of these areas? That's highlight the lack of access in palliative care. That is really a very huge problem. But you might say maybe a dedicated palliative care team is not needed everywhere, and I agree. I'm co-chair of the Primary Palliative Care Reference Group. But there is in Guatemala only one medical school teaching palliative care. And if we look at this proxy indicator of the distributed opioid morphine in equivalents, in 2000, that is from the Atlas of the Latin American Atlas, they have in the median average between 2015 and 2019 was for the importation, the distributed opioid in Guatemala was the 38 kilograms opioids in morphine equivalents. You can see most of them fentanyl, expensive one. No? If we calculate about 1 kilogram of oral morphine can cover 100 patients with cancer, a dosage of 100 milligrams for 100 days. That means that the whole imported opioids in Guatemala would cover less than the half of the patient with cancer. If the whole opioids are used only to take care of these patients, also no another medical use like surgeries, emergency, patients who survive, nothing more, that highlights the unmet need for pain management and palliative care in Guatemala. as example. But let's look the other extreme, and it's Brazil. In Brazil, Valentino and other colleagues studied the preference of the place of death, and in Sao Paulo, that was exactly in Sao Paulo, and they say how many people would prefer die at home. However, only 50% were able really to die at home in the same, I hope the same people. And my colleagues, Luis Fernando Rodriguez and Fernando Marcucci, analyzed the mortality data inside of Brazil, and they were able to see the difference inside of Brazil according to the socioeconomic development of the regions. And the conclusion is, the higher, the richer is the country, the region, the state, the more people die at the hospital. That is similar to the studies of Lopez and da Silva that analyze the regions, the trends in the regions. And Fernando Marcucci also shows that in Brazil in the last year there was a huge amount of people dying. This tendency to die at the hospital has highlighted, and here is the COVID pandemic. Well, for people with chronic conditions, I compare here the different chronic conditions and the world population in Latin America. The most, people dying with neurodegenerative disease, also dementia, they have more chance to die at home. And Paula Hidalgo explored this topic and found a significant percentage of people with dementia dying at home, especially in Guatemala, El Salvador, and the countries that we have they said before, and with less people, or the people dying, with more people dying in the hospital in Brazil and Colombia. And in a qualitative study, caregiver said that during the last hospitalization, that is the doctor of a woman who died with dementia, she said during the last hospitalization, the hospital gave her plaquettes, platelets, hydrate hair, insert a feed tube to nourish hair. Since she wasn't eating, her potassium level was low, so they raised them. In a sense, all her vital signs and everything were in poor condition, and they started working to stabilize and restore her health. And she continued, there was prolonger there, we prolong her suffer. Wouldn't it be better for her to go through her natural process and pass away? I mean, there was no way to save her, and her quality of life wasn't going to improve. Doesn't it make sense for me to extend her life by a month or two? In this case, it was a month and 10 days for my mom, but at what cost? Also, her story vividly contrasts with the other picture of Monica Lalanda that often illustrate the die at the hospital. The mother died alone with the feet, with the well condition, with the well things around, blood and everything, and at the hospital, which had a very hard impact in the family. And we have here the questions to the caregivers. According to the Economic Commission for Latin America and Caribbean, the CLAC, in Latin America, the burden of caregivers is expecting to increase. They say that in 50 years, one person in Chile should take care of 3.5 persons. And if this burden is only for the woman, that means that one woman in Chile, in this age from 16 to 70, I think that's the range, will take care of 7 people at the same time in 50 years. And so this is a really caregiving crisis where women are disproportionate the burden. And here, journalist Irene Vallejo make analysis about this burden. Well, what is with children? My pediatrician friend said we have always to look at children differently. Well, we look at the children with complex chronic conditions, and we saw that most of the children with chronic complex conditions are dying also at the hospital, even in countries with a much more development of pediatric palliative care, like Argentina, Chile, and Costa Rica. They are dying, most of them home. Most of them are the children at the hospital. Most of the children dying at home are with those with neurological conditions compared with other conditions. There are factors associated with the death, yes. We found that some factors are associated with the place of death and are, for example, cancer, solid cancer in comparison with the hematological cancer. The people with dementia, as I showed you before. Individual factors as age. The older the people are, desto more chance have to die at home. Also, those living in rural areas or with lower educational levels. That means that that the socioeconomic status give much more the possibility to die at the hospital, and that is quite different what's happening in Western Europe and North America, where the resources are used to facilitate home deaths. Cultural factors like the perception of end-of-life care and the preference, as I say, the preference, a bigger preference to the home is also very important, and the family and the religious belief also they are important in this situation, in case that there are some possibility to choose. No? But also the context, legal aspect, for example, the certificate itself, also to sign the certificate is one reason why people take the family member in dying process to the hospital to be able to have the certification. Or the geographical factors, where there is some places where it's not possible to go inside, and people are, so because the violence and the problems that they have, also there is no chance to go out of this place and they stay home. But it doesn't mean that they are in a good care provision. Also, the resource availability. There are people with a lot of resources, they know about palliative care, but they are not able to find somebody who can take care of them. Also, a friend of mine say, well, these people engage a nurse, and she stayed there and say, I don't have no idea what can I do with this patient. It was for our children with a neurological condition. Well, in Latin America, there are some values that is very important at the end of life, like the families, this strong family connectedness and interdependence, the personalism, which is this very warm and personal relationship with the medical doctor, and the personal respect, which is very important, this opinion of the medical doctor, because there is authority and rank there. Well, and other characteristics like the fatalism or religiosity. That is an important coping strategy. Additional aspects are the meaning of the death at home, the access of healthcare, the resources at home, the social network, long-term care. There are not so much long-term care. Informal end-of-life costs. The family has to pay for the care of for this informal care, which are not trained. And the legal and regulatory aspect, as I say, the certification and the palliative care provision are much more at the hospital. Also, there is a big challenge. Who can the people really die? It's not really a choice, but where they have the chance to do it. Or, yeah. It is possible to die with palliative care in Latin America. Yes, a friend of mine in Argentina, he said, with adequate home care is possible, and 24/7 nursing is significant. It's possible to reduce the death rate in the hospital. I finalize my presentation with a final reflection. Latin America face triple burden of disease, non-communicable infectious disease with HIV and tuberculosis, and huge and the violence, and huge inequalities. The lack of universal coverage of specialized palliative care at the end of life. And we have that home is not necessarily an indicator, because it's often the reason of lack of resources and not really a decision with good care. It's possible, but it's not this is much more deception. There is information about where and what can be improved also with this kind of research, and hopefully to improve the investment in palliative care. And some methodological reflection, as Joachim said, these data are essential to analyze and understand the trends in the place of death, both in the country, but within the country, but also across the countries. And we have the need for better data and standardized studies that allow comparisons, and of course, the collaboration and networking. Well, I thank you very much for your attention. Pass to Joachim or Barbara.
Thank you very much, Tania. I think that's a wonderful presentation combining many country comparative descriptions, but also zooming into more case-oriented approach. And I think it really helps us to appreciate the heterogeneity of situations also in Latin America. So very useful. I can imagine that many people have small questions, but also bigger discussions points. I reiterate my point. Please put them in the Q&A, or you can also use the chat, but preferably the Q&A, and we will address those points of clarifications and discussion at the end of the session. I will now hand over to Barbara Gomes, who is going to present also on place of death and linking to her ERC project. Barbara, the floor is yours.
Thank you. Can you hear me well? And can you see well as well? Great, yes. Wonderful. It's a great pleasure to be here with my friends, Joachim and Tania, to talk about place of end of life care and place of death. As Joachim mentioned, our group is currently working on this matter for 5 years with a grant from the European Research Council. So I'm fortunate to have the time and the resources to dedicate to this topic. Some of you may have seen the paper which was published in JAMA just a few days ago, showing a negative trial of palliative care in the emergency department. And the editorial that came with it called for dedicated attention to when, where, and how palliative care is offered. So in this talk, I'll be talking mainly about where, but although the other questions are also very important, which is when and how. But place is important as well when we look at the global burden of serious health-related suffering. And I'm here showing the projections that Catherine Sleeman did with others a while ago, showing how the burden of serious health-related suffering and palliative care needs will increase immensely in the upcoming years. So from 26 million people who died from a range of conditions that would benefit palliative care in 2016, it will go up to 48 million in 2060. So it's important to think about where these people will be living, where they will be receiving care, and ultimately where they will be dying. So place of death is one of the few population-based indicators in health. It's not just in palliative care, in health. It's an indicator with a very long history. And just a reminder about what the term population-based means, as opposed, for example, to service-based study, for example. Population-based study is a study of a group of individuals which are taken from the general population as sharing a common characteristic. In this case, people who have died and they died somewhere. So it's important to know where this takes place. And in many countries of the world, but not all, as Tania pointed out, in many countries of the world, death certificates have an item in which people who fill in death certificates, usually doctors, record where death took place. So as Joachim pointed out in a very interesting paper he published a while ago in 2007, so nearly 20 years ago. But he was flagging that actually death certificate data provides a unique opportunity for us to study and monitor place of death cross-nationally. And bear in mind that we look at place of death from a palliative care lens or end-of-life care interest perspective, but this is information which is recorded for all causes of death and may be helpful for other purposes. So, for example, if we're thinking about accidents that take place in the workplace, or if we think about suicides, it's important to know where these are taking place as well. But of course, many of the studies about place of death come from an end-of-life palliative care interest and palliative care people, as we all in this presentation. Recently, our group from the Well in Place project is conducting a systematic review of comparative death certificate, place of death data studies, such as the ones that Tania has conducted and Joachim has conducted as well. And I'm here highlighting these two types of information which are coming up in our systematic review. So you've got the scientific papers, as the paper from Adair on home death proportions around the globe, but also compilations of international statistics on place of death, such as the one conducted by the OECD and recently published in a new policy brief they published in November last year. So this is a sneak peek of the presentation we'll do, and this is work led by Inês Gomes da Silva in our group, and will be presented at the EAPC Congress. Adding to Joachim's point about the opportunity of studying place of death as part of the death certificates, I add this further opportunity, which is the move from paper certificates to digital certificates. And in Portugal, this is one example. In Portugal, we made this move to a mandatory electronic system for certification of deaths in 2014. And you can see here, of course, it's in Portuguese, but you can see here that it opens possibilities of making changes in a more flexible way if we want to improve the certificate, but also it can go back, it can go down to the level of even choosing in a drop-down menu the institution in which death took place. Place is really the tip of the iceberg. So there's a lot of intangible things we don't know about, and they come associated with place. We don't know whether symptoms are controlled. We don't know about the quality of death and dying. We don't know about grief. And so we don't know if the person died alone or not. And some of these things that we have tools to capture, some others are more difficult to capture, whether the person died at peace or not. But there is something which is observable and more objective, which is place, and it's information which is accessible for a whole population, if we're talking about death certificates, or nearly a whole population, if we take into account that the completeness of death certificates is not 100%. So it's an important first step that will enable us to understand some parts of a reality which is relevant for palliative care. Policy decisions influence place, and the work by Young and May is very important, showing these associations in Europe, and they found that when palliative care provision in a country is in line with the EAPC recommendations, there's a reduction in the proportion of people who die in a hospital. If the level of long-term care expenditure covered by the government and compulsory insurance is high, there's a reduction as well. These are not big reductions, but they seem to have some association with place of death. So these are policy decisions which at some point, to some extent, are modifiable if countries want to. Another way of looking at it is, okay, policy decisions may have an influence, but actually, do policymakers dedicate attention to place of end-of-life care and place of death? And this is another sneak peek of work we're doing in the Well in Place project, which will be presented at the EAPC Congress. Sifra van de Beek from our Dutch team has conducted a policy document analysis in our 4 target countries, which are the US, Portugal, the Netherlands, and Uganda. And just to give you a highlight here of the kind of documentation we're finding in Portugal and the Netherlands, for example, we have national strategies or national agreements which prioritize home, but are very different in, for example, in Portugal is a very comprehensive strategy document. In the Netherlands is a very short agreement, but which ring fences investment in this field, which is very important. And in Portugal, the aim was very ambitious to increase the number of home palliative care teams, a target which was largely unmet, even though with some progress made. In the Netherlands, it's the focus is slightly different at this stage of development. They are very much focusing on providing a spiritual care at home, training volunteers, and so on. So a more community-based perspective rather than professional, focusing more on professional. Just to give you an example of 2 very different approaches to considering place. And in all of these 4 countries, we did find some policy attention to place at the end of life. But let's go to the facts where do people die? And actually, Tania showed already some of these. More recently, last year, we conducted a 32-country population-based study of death certificate data of a decade, covering the first 2 years of the COVID pandemic. And we showed that in most of the countries, there was a rise of home deaths in the pandemic years. And this was more expressive, if you want, in the group of people who were dying from cancer. The home death percentage in cancer rose from 36 to 43%. And in this slide, you can see the differences between the countries. And I'll take just a few seconds here so you can locate your own country. But for example, in my country, in Portugal, the trend was completely different. So as you can see, the percentage of home death was decreased in the pandemic years, and it was actually following a long-term trend of decreasing home death rates and increasing hospitalization. So things may vary between the different countries, as Tania also showed for Latin America. But within these 32 countries, we see some countries where actually the trend of rising home death was fairly stable and even present before the pandemic. So things were already shifting towards more people dying at home before that. And some of these changes may be linked with some policy measures taking place. For example, in the UK, there was in 2014, there was an introduction of an end-of-life care program, very much with a focus on enabling people to die at home. So in the UL project, we're providing this evidence and sharing with policymakers to try to engage them and so they can dedicate more attention and consider place when they're thinking ahead of palliative care provision. So we not only we publish the scientific paper, but we do a policy brief which we circulate to policymakers, and international associations of patients, carers, and palliative care professionals also drew together a joint statement based on the data we shared, highlighting important messages for policymakers. And you also see here policy briefs from the European Commission, and most recently as well from the OECD, with some really interesting suggestions for governments to support improve the distribution of public funding for long-term support across settings, to increase the availability of home palliative care staff, and also to support family carers, which was another very important aspect that Tania raised as well. I also would like to talk more about facts, and here you see a question which is related to preferences. So we looked at where actually people die, but where would people prefer to be cared for at the end of life, and where would they prefer to die? And I've been studying this matter for over 20 years now, and the preferences angle was always my initial target and goal and reason for being interested in this topic, and still is. And our group also conducted an umbrella review, which I urge you to read. It has a lot more detail than is showing here in the slide. But we found 15 systematic reviews, and this body of evidence is composed by 229 non-overlapping studies. And of course, the main message is familiar to many of us, that the most common preference is to be cared for and to die at home. We found two meta-analyses that support that between 51% to 55% of the patients would prefer to die at home. But as you can see from the figure in the left side of the slide, it's not only home that people prefer. There's variations, there's hospitals, there's hospice, palliative care units, nursing homes, and even rarer places. And I think the other value of this umbrella is to highlight as well this group in the middle, which you can see here in the middle, of people who actually have no preference, or they don't know, or are undecided, or they don't even want to think about it. They're unwilling to express a preference. So I think a very important message from this work is that there is variation that we should accommodate when we're thinking about where to put resources in place. And there's also people who have a preference for against home, and that seems to be higher in urban regions. And I'm going to try here Slido. It's the first time I'm using Slido in a presentation, so bear with me if it doesn't work very well. But I would like you to try scan the QR codes with your camera in the telephones. And I would like to ask you the question, where would you prefer to die? And you can see here that obviously I'm not sharing with you a very comprehensive classification of place of death, but I'm showing you some categories which sometimes we don't even think too much about them, but they are places that are coming up from our work or from us contacting with a reality that puts them, sheds light on them. So for example, you have, of course, the emergency department, triggered by the RCT that I mentioned earlier on, that published in JAMA. But also, I'm not sure if many of you saw the film, The Room Next Door, but which is a very, very nice and interesting film, but temporary lodging house with the purpose to die there is something that comes up there. And of course, you have other places here in the survey. So this is your results. Private dwelling, where you usually reside, is coming up as the most chosen one. Hospice or palliative care facility in second, which is very much aligned with the evidence we know. Usually these places come at second, but just to give you an idea, of the 32 countries that we studied, very few actually had in the death certificate a hospice or palliative care facility option. So yes, thank you for interacting with this survey. Of course, we are a very special audience here of palliative care providers and researchers as well, who know some of the implications of these options. And I also wanted to share with you the sheer number of categories that are used across these 32 countries, which we grouped in 4 main groups: home, hospital or health institution, other defined places, and ill-defined places, which we highlight here are an important consideration. So this is where people tick elsewhere, or where place of death is unknown or unspecified for some reason. And across the 32 countries, 11% were deaths recorded in ill-defined places. So 1 in every 10 persons, we don't know where this person died. And of course, the most common group was home across the countries. But what is home? It could be an ideal picture of home, as you see in the top of these slides, with a garden, a very nice house. But sometimes home for people is not in this idealized manner. It could be a house with sometimes poor living conditions, but that people view as their home, and they may even prefer to die there, with a trade-off of not having the perfect scenario at home. It could be the house of a relative where you need to move in if you need support. It could be a nursing home, it could be a prison for a prisoner who spent and is spending all of their life there, and they don't have a home elsewhere. A convent, it could be a street for an asylum seeker who's living in the street and has some sort of home in it and sees it as their home. So home, of course, has a subjective meaning, and it may be more of a qualifier than actually of a place, than the actual place, the objective factual place in which people are. So knowing all these and learning every day with this evidence that I just showed you, we came to realize that we needed something different in the future, and we needed a global codex that could enable us to do the studies that we are doing in a much better way, capturing things which are important for people. And so we're developing an international classification of dying places, very much grounded on what these places mean for individuals. We're doing this for over 5 years, using qualitative and quantitative methods to gather evidence to inform the classification, and we will then test and validate the classification in the 4 countries that are the target countries in our study. And if you're interested in the project, you can read more in the protocol we published in Palliative Care and Social Practice. We have work underway, the document analysis that I mentioned to you before. We interviewed key stakeholders in each of these countries. We also surveyed internationally key research groups working on place of death. We are conducting qualitative serial interviews with patient and carers in the 4 countries, and we're about to start a survey of bereaved relatives in the 4 countries. And this will capture the last months of life of people, adults and children, dying from a range of diseases, not just cancer, but some non-cancer conditions. So I'm nearly towards the end, just urging you to be involved and to get involved in this development of the classification. This is a save the date. If you want to scan again the QR code, we're organizing a pre-Congress, pre-EAPC Congress event in Helsinki. If you haven't booked your flight and want to attend, this is free, but you need to register. And this will be in the afternoon, in the day prior the conference. So we'll be presenting the draft classification and getting feedback from people. And we would very much welcome feedback from different countries, different languages, different cultures as well. So my 3 final points for discussion are that there is diversity of places, in preferred places, in actual places, and we see some population patterns, but we also see individuality. And I think it's important that we realize these both coexist and should be accommodated. There is some policy attention, and we're very much focused on trying to take the most out of it. And we researchers and care providers can help policymakers ensure their actions are adequate and their investment in the different settings is adequate too. And finally, we're very much focused on taking out of the most of data on dying places. It can be improved, and we believe that with the international classification, this will be improved. Thank you.
Thank you very much, Barbara, for this very broad overview on this issue of place of death and dying. I'm going to open the floor now to a number of questions. Again, I repeat my recommendation for people to put questions in the Q&A, but there's a couple of questions that have already come in during your presentations, but also some people sent in questions ahead of the webinar. And I think some of the questions are more about data and methodological aspects. There's questions that are more about the causes or determinants, the reasons why we see these differences that you have all discussed. And some are more about what does this mean? How do we set up services so people can actually be enabled to die in their place of preference? But maybe starting with some of these questions about data and methodology. So today's webinar was about international or cross-national comparative research, and both of you have shown these comparisons. And I suppose there are a number of issues or challenges for international comparisons. For instance, Tania, you have showed sometimes these comparisons are difficult because the same things mean different things. But what is it? And the question is a little bit, how do we make these comparisons meaningful? There was always also someone who sent in a question about how do we select the countries if we're doing international comparisons, and are we comparing apples and oranges? So any advice here on what to make and how to improve international comparative research in this domain?
Tania, shall I go first? I think the question about the choice of the countries is a really important one. I think sometimes it's for convenience or for focus. So, for example, in Tania's case, the focus was on Latin America, and in our case, for example, the focus was on Europe. But outside Europe, we selected countries trying to capture some variation in UN regions and also in countries with different levels of scores of the quality of death and dying index. Because we were hoping to see some possible link between the distribution of the place of death and the level of development, for example, of palliative care, which we didn't actually see so much. So I agree. It should be there should be a clear reason for choosing countries, I think.
Tania, anything you want to add from your experience about choosing the countries? And
yes, as Barbara said, my focus was in the region, as Latin America, but I think some of these countries who not participate. I think that is a possibility. There are data there. Yeah? The certificates are there, almost all countries. And I think the data are there, and this is a possibility to take a look. I like very much your point of the iceberg. Yeah? This is to look what's happened there and to think from these numbers, for example, to think about what happened behind that. Yeah? What is the quality behind that? And as Joachim said, it's not doesn't mean the same from the different countries. We have a lot of interesting discussion with my colleagues from the different countries speaking about this data, And I think well, if the data are there, I will look at them, I would say, no? And to compare. I think there is a power in the comparison because sometimes we are overwhelmed with the one situation, but we look at the neighbor country. For example, in this focus group that we did, in some countries say, wow, indeed, the science, the certification is a problem in the country. And people have to take the dying person in the hospital so that they are not able to die at the home, not in the ambulance, but in the hospital so that they can get a certification, which is really, and they began in this country, to look other forms to do this simple thing like a certification. And so it's, well, I think if you have data, look at them. Sure.
And I agree, it is a big challenge in international comparative research. Is first of all, you can of course compare a lot of countries and just juxtapose them to each other. But then, of course, the big problem becomes like, are we comparing the same things? Do they mean the same thing in different countries? So I guess in a methodological terminology, it's a problem of conceptual equivalence. And I think what you have shown in your presentations is also that sometimes a hospital means different things in different countries, and a home death also has a different meaning. So it's really a question of, are the concepts that you are comparing, and this could be the same if you're, for instance, comparing the contribution of receiving palliative care, do they mean the same thing across countries? I think the solution is in both being critical about wondering what are we comparing and what countries are we selecting on what basis so that we have comparability, but also contrast, so heterogeneity, and also combining these more quantitative, variance-based descriptions with really case-oriented descriptions. So a bit like you've done in your presentation, Tania, where you zoom into the cases, it really helped to understand what does a home death mean in even a single case country, but it could also be a few cases. What are the reasons that people die at home and in hospital? So it's really in that combination that we can learn more from these international comparisons. You both mentioned that, well, the importance of other data. So use the data that are there. And Barbara, your presentation talked a lot about the availability of opportunity of available data, that certificate data, digitized data. What other data do we need to improve our understanding of palliative care issues, of place of death? And are there any opportunities that are already there that we're not using?
You mean on other indicators other than place of death?
Well, maybe beyond that certificate data, and maybe the data aren't there yet, and we need to drive our governments to collect those data.
I think there's, well, as I was preparing this talk, I was thinking about other population-based approaches to studying things that matter to palliative care. And another population-based approach we have used in the past is to do surveys of bereaved relatives identified via death certificates. So you get still the same population-based approach, but you get more insight on other variables beyond place of death. So, for example, that's an alternative. Another subject I've been most interested is about the aggressiveness of the care people get towards the end of life. And there's routine data. In some of the countries, this is surveys-based, but in others, there's good population-based registries with this sort of data. And I know that you share the same interest in this topic, and the analysis of big data is another opportunity. And now with AI and other methods, we can certainly take more out of this existing data too.
Mm-hmm.
Yes,
Go ahead,
sorry,
Tania.
Well, I think a lot about that, especially on how to identify the integration of palliative care. If we speak about integration, especially for example, in the primary care, well, I say in primary care, and I wonder, is it possible to have some indicators at the primary care level? I know, as medical doctor, I know we have data about the quality of birth giving, about the amount of vaccination in the children, and I spoke with some people at the WHO. How can we have some indicator also for palliative care? Can we have one of them? Because, well, I don't know. I'm so sad. But there are some countries who have some indicators in the GP practice, or some code for, and interestingly, in Ecuador, the death certificate have a part where it is about did you have provision, palliative care provision? I thought this is interesting, where they both think are mixed. So maybe we can do that. And Barbara, for your suggestion, you can do that to suggest to have some. We don't know about the quality, but we don't know about the quality of anything also. But there are some indicators if they think about it. There is some palliative care.
Okay, interesting. So I understand, like, there is some data that help us, and we need to use that data to the best as possible. But then maybe, like you suggested, Barbara, we need other data, and maybe commission our governments to also collect those data if we really want to understand what's happening here and set up the appropriate support as a population health perspective should be doing. Maybe looking a bit at determinants and causes of why there are these differences in Latin America, but also in other continents. And there were a couple of questions in the Q&A about what about financial determinants of place of death, and specifically also a question to Tania on, are hospital bills a big factor in Latin America? Or maybe we can turn around that question. Maybe accessing hospital is maybe a cheap option. Is it an expensive? Is it really a financial determinant? Or
yes, I talk about the question. Hospitals. Well, there are different healthcare systems in Latin America. Some of them, for example, in Colombia, hospitals are for some population free of cost. But there are always costs involved at the end of life. So even the transportation to the hospital, there is it's implied with. But at home, and some of them are private, as you have to pay. My grandmother was in a private hospital where people have to pay a lot of money every day for in the year. But at home too. At home, the caregivers, also the payment of the caregivers is a huge cost, and the caregivers are often not trained, as I try to say. Yeah, so we know the costs at the end of life are very high, and this cost is often in Latin America, let's feel into the family in most of the countries. But Uruguay is a little different. They have a better healthcare system, as I know. But but in most of the countries, any cost is felt on the family, and this is really a problem because the poverty is a problem in Latin America. And now, now after the COVID crisis, there is a reduction of many things in the region. This is, well, I would say that.
Mm-hmm. And a question linked to that was, can you tell, and maybe a question to both of you, can you tell a bit more about socioeconomic differences, like people's material, but also cultural and social resources? How are they kind of discriminatory in terms of accessing or being able to die in a place of choice?
Yes, and there is also additional to this transportation is for example where people live. Also if somebody lives in the Amazonian, in the forest, there are not health facilities around. also in very rural areas. There is no facility at all around for also where they live. Also the geographic concern is a problem. We did some research also about the access to palliative care, not exactly the place of death. For example, in Ecuador, where some people still don't speak Spanish. They have other indigenous language, so local language, and they have problems to the access, to the access to the healthcare provision, and to access, as somebody asked about, also to the medication. In other study about the opioid price watch with the International Association for Hospital and Palliative Care, we find out, for example, that in Honduras, ample morphine can cost $10, which is for them a huge amount of money that they can afford to pay. This also and sometimes this is maybe something good. Sometimes at the hospital they have much more access to some medications as at home, as in the community, but not necessarily. In another case, from the wife of a friend of mine went to the hospital with at the end of the life, but in the hospital the medical doctor were not able to formulate morphine or some opioids because they were not trained. They waited until the palliative care doctor came and prescribed some increase. She has already morphine, but to increase the dose. Also, it doesn't mean that at the hospital necessarily have a better provision. They have more chance to have, for example, opioids, but it doesn't mean they guarantee good symptom management. But I notice that it is the fantasy that we have in the community that maybe, as somebody say to me, yes, but at least they can have some care. And that is the idea, at least there is some care. First, there is not always a hospital close, but in the hospital, we know that is not necessarily also a good option, as they are not trained professionals, they are not palliative care teams, or also they don't have to palliative care specialists, but they are not training in palliative care. Also that is less the people in a very, very difficult situation. And it's really concerning. For me, it's really to think about the amount of people, 2 million people in Latin America dying with pain, with suffering, and that we can be controlled with very few interventions that we know about it. This is not something magical. We know about it, that this doesn't happen. It's really, and I say that's the poverty, that's the cultural component, that the environment, let's make a place that make a role in order to have a very, very difficult time at the end of life. Yeah.
Can I just add something on the socioeconomic issues, disparities we know exist, and that was actually the driver for Irene Higginson in very early stages to explore the link between deprivation scores and place of death within the UK, and even then comparing with New York, for example, London and New York. So we know there's an influence, and that, for example, ethnic minorities are more likely to die in hospital. And I think, but it also, I think, should be understood within the specific context of a given healthcare system as well. So if you have a system where hospitals are very freely available in a public system, and people will go, and usually the main gateway is the emergency department, and again, sorry for highlighting this setting, which is very in the news at the moment, but it is an important setting. And again, it's not a setting which is included in their certificates in many countries. We found only in 3. But for example, in Portugal, we have about 12% of people die in ED, and the percentage is much higher in people dying from dementia. So, and because it's an accessible resource, and there's not a lot of formal support in at home. So people move, sometimes not driven by preferences, but because of lack of options, really. And as Tania pointed out, because of a perception that actually care is there, whether at home there isn't much. So yes, I that leads to the point as well that Joachim was saying. Sometimes building up case stories that flash these statistics that we show is important, and that's also why we are following patients and families through time qualitatively to try to tease out some stories.
Yeah, and additional, also the studies in Brazil have shown, as you say, now that white people tend much more to die at the hospital, which are much more rich, yeah, also Asiatic origin, and Black and indigenous people from local Americans, they also have more chance to die at home. Yeah, so, but it shows a lack of provision, care provision, not because there's a choose, and people who has a better economic situation and even know about palliative care, they don't find the people to care of them at home. So they have to go to the hospital because there is not other possibility. So this is really, I mean, at the end, yes, people enter the hospital, the more money, the more is that we found, the more money and the more situational status education, they more chance have the resource to die better as they want to. And it is at a hospital where there is neither palliative care. It's made me so sad because at the hospital there is neither a good palliative care provision. So I will be happy if they find something there, but it is neither.
So you both talk a bit about interventions, strategies, policy aspects that would be needed to improve this situation, to make it more accessible to many people to die in their place of preference. But what are the strategies or interventions that we need to look at? What do we need to invest in? Because I think, Barbara, you also showed that difference between the Portuguese and the Dutch strategies. Do we need to focus on setting up more palliative care services, 24/7 services, which, like you showed, is an important factor to enable a home death? But we're also in a context of scarce resources, increasingly so. Definitely in contexts like Latin American countries sometimes. There's also people in the chat who are asking about African context. Do we maybe also need to invest more in strategies, policies that look at kind of supporting family situations and what are the promising strategies? There's some reflections there.
I would say people want to be cared, and if these strategies is about how to provide care at home, it will be as I show in the interview that people will be happy, will be ensured. Okay, I can deal with this situation. We are doing different things about that. For example, this so-called death literacy, also to encourage people to be able to deal with the situation at the end of life. In some interviews, a woman said, "I would like somebody to come to me and show me how to turn my mother, turn around, and just to know I'm doing that right." I see so lack of support, even from the healthcare system. But on the other side, the healthcare provider, they also need to know too much about how to do with the situation, as I show in the example of my grandmother. I'm sure she wants to take care of my grandmother, but she didn't. The only thing that she has is some intravenous thing. Also, this is their strategy. But they need also for me, is education education of the healthcare provider, but also education of the community and how to deal with this situation at home, and to have some support in case that something happened, for example, indeed a seizure or something like that, that they can call and say, because it is the wish, and it is we know that is the much better, it is a very good use of the resources if people are care, but Barbara, sorry.
Barbara, brief reflection.
No, I think there's reasons, evidence-based reasons for prioritizing home. In some cases, will be concerns with people dying at home because they lack the supports there. In others, there's plenty of support. Hence, that's why they're dying more at home. So we know from, for example, a Cochrane review we've done a few years ago that home palliative care teams double the odds of people to die at home. So we know that has an impact. But I think an important message for policymakers that really they should take place into account. It's not just home, it's also other places which are important to think about. Because there's variations, not only in actual, but also place of death, preferred place of death. And they also should consider the issue about continuity of care, and individual pathways will differ, and people end up in different places, and services need to exist to the right proportion in different places. So that would be my message, I think.
Well, but a problem with that is, for example, in Latin America.
Tania, because I will have to wrap up because I see it's 3 p.m. So we will have to wrap up the session. But I'm just want to go over a couple of slides very, very quickly for the announcement of future events of the reference group. The first one is that the one that Barbara already announced. So if you want to see more about Barbara's research or about Barbara or both, you can go to this event, which will be taking place adjacent to the EAPC conference. So it's readying for end of life in place, helping shape the international classification of dying places. So an event that is co-hosted by our reference group. Then our reference group organizes research seminars every other year. And this year, it's going to be the 4th International Research Seminar, and it is taking place in Canada. This is a reminder for those of you who haven't heard about this interesting research seminars. The deadline for abstract submission is coming up very soon, 31st of January, although there might be a good chance that the deadline is going to be postponed a little bit. But do look at the information that you can find here and put this into your calendars as a very interesting research seminar in British Columbia. There's a couple of symposia that we are co-organizing, and there is this one that is taking place very soon in March in Brussels on death literacies, so end-of-life literacies, death literacy, grief literacy. And there's a QR code to register for this symposium. And then finally, our reference group is having an open meeting at the EAPC conference in Helsinki. And we actually have an open call for all of you if you want to present research, art, or any other stories that you would want to share that have a relevance to public health and palliative care. We are organizing this session in a Pecha style of session. So it's basically 20 images, 20 slides, 20 seconds each. So it's about 6 to 7 minutes of presentation. And we are open to any kind of contribution, and everyone is free to submit their IDs using the QR code here. So if you are interested in sharing something, it could be research, but it could be any other topics, we are open to your IDs. So with that, I want to close the session, and I would like to thank our 2 speakers who have done an excellent job in presenting, but also answering all these questions. Thank you very much and have a good day, everyone.
Thank you.
Thank you for sharing brilliantly.